So, dear Professor Kotsis, dear ladies and gentlemen, dear friends, and once again, thank you for the invitation. So, following pregnancy is the beginning of life, obviously. So, if we are alive, we may develop diabetes, and luckily for us, physicians, we may even develop diabetic complications. So, we never run out of a job. And we're going to discuss something very bizarrely specific, which is what effect does glycemic control have in neuropathy, and whether there's a difference, and indeed there is, between type 1 diabetes and type 2 diabetes. So we do care about pregnancy, obviously, within diabetes or not, but why do we care about diabetic neuropathy? What do we do? You bet we do, because it contributes to diabetic thoughts, the complication of complications, because it may lead to neuropathic pain. It may lead to gait instability and disorders, to cardiovascular and gastrointestinal morbidity and even mortality, to erectile dysfunction, which may prevent pregnancy, and to depression and other things as well. But let us be reminded of a relatively new observation, which is now actually more than 10 years old. And that is our review with Professors Winnick and Ziegler, that even in subjects with impaired glucose tolerance, so with prediabetes, by exception, roughly 10% of these may develop neuropathy as early as during prediabetes, and vice versa. When you do the diagnostic workup for allegedly cryptogenic neuropathy, idiopathic neuropathy, you should run tests for OGTT. So this increases the importance of neuropathy in as much as it occurs early, as we shall be seeing in diabetes, but even earlier, that is to say, during prediabetes. And that justifies the approach in discussing such concrete and bizarrely specific issues as I will be touching upon. So diabetic neuropathy, what are the therapeutic targets? Obviously, optimized glycemic control, but also the holy grail, which is pathogenesis-oriented treatment, pain relief, which we're good at, and avoidance of risk factors and complications. Pathogenesis-oriented treatment aims to halt the progression of neuropathy, like you see the statue here, or the street artist, if you will, who's pretending to be the statue, and those kids playing claudication, playing standing still after the statue. So pathogenesis-oriented treatment aims to stop the procedure and to halt prevention. And we're all familiar with alpha-lipoic acid. Aldose reductase inhibitors is for older gentlemen and ladies than us. And protein kinase C beta inhibitors are probably disappointing. So glycemic control in type 1. That is an easy thing to ask, a very easy thing to answer. DCCT edict at 13 to 14 years. Well, it is self-evident that green is better than red. And so intensive treatment leads to reduced incidence of neuropathy versus standard treatment. But this is in type 1. Life is simple. And my mentor, Dan Ziegler, was fortunate in following patients for the first 24 years after diagnosis of type 1. And he showed both as regards small fiber dysfunction and as regards large fiber dysfunction. You see green is better than red, so warm thermal perception threshold and cold thermal perception threshold. It is lower, that is to say better, with intensive treatment rather than with conventional treatment. And as regards large fiber dysfunction, peroneal motor nerve conduction velocity and sural sensory nerve conduction velocity. So green is higher, so quicker, so no reduction in nerve conduction velocity. So protection of large fiber function, protection of small fiber function. If you treat them intensively for the first 24 years after diagnosis of type 1. And this is the Cochrane database systematic review, 1,200 patients, 3 trials, high quality evidence. 65% reduction in neuropathy with intensive treatment. And more recently, with or more effectively with pancreas kidney transplantation, you have improved corneal nerve fiber density, a modern method of estimating small fiber function in the cornea of the human eye. So more nerves, better nerve conduction velocity, and fewer neuropathic deficits. By contrast, what happens in type 2? Well, this famous or notorious or infamous or whatever Cochrane database systematic review, as source of wisdom, said that it is effective, but not significantly so, at 0.06. And this summarizes the effects of many interventions in type 2, from the UKPDS to STENO2, and we see most of them have been neutral and very few have been fortunate in showing improvement in neuropathic deficits. For example, the UKPDS in just a subset of people and in VPT, vibration perception threshold, and Lord, by God, in the hands. So very strangely looked at the hands and only in a subset of people. So positive effects are very rare. And Callahan, again, whom we've already mentioned, summarizes that glycemic control has a robust effect, but not in those with type 2 diabetes. Which brings us to the old masters at Steno, who were fortunate in showing 60% reduction in autonomic neuropathy, doing what was best at the time, that is to say statin, ACE inhibitors, better glucose control, better blood pressure control, torturing the patients, and so on. Another important but still neglected issue is which way we go. And it's a long way to Tipperary, but it's also a strange way when you try to cure neuropathy, because you see that the red line, the red solid line, which is insulin sensitizing agents, ergo, metformin, and pioglitazone, was better than the insulin providing agents, which is the black dotted line, and that is to say sulfonylureas or insulin. So the way you reach a glycemic target may be important in as much as using the red approach, the insulin sensitizing agents, you had a reduced incidence versus the other approach. But we need to know more. And we can ask ourselves, is something really wrong? And maybe in type 2, the pathogenesis of neuropathy is more complex. Or maybe our evaluation of neuropathy remains inadequate. That is our Greco-German publication in which we're showing that neuropathy in type 2 has a complex pathophysiology encompassing hyperglycemia, dyslipidemia, hyperinsulinemia, inflammation, advanced glycation end products, and many, many deleterious pathways. And this brings about the issue of seeking new approaches. So what does the future hold? Or are there really biofactors which can be measured and can be used? And the other issue is, of course, how we should improve tools for early or for more accurate detection of neuropathy. And one of them is, of course, corneal confocal microscopy, which deals with the already mentioned corneal nerve fiber density parameters and so on. So it measures quantity and quality of small fibers in the cornea of the human eye in vivo. So how do we improve neuropathy? Well, we're looking at patients' feet, because that's where peripheral neuropathy is, which is the commonest manifestation of neuropathy. And in both diabetes types, we should improve glycemic control, but avoid too rapid improvements and avoid hypoglycemias and fluctuations. And this approach is more effective in acute neuropathies, so acute painful neuropathies or acute cranial neuropathies, which even per se have the good tendency to recede. additional considerations. Shall we to ask or not to ask? Well, alcohol abuse is in itself neurotoxic, hypertension, smoking, and dyslipidemia. And I would add obesity, so that you are satisfied and proud, Vasilis. But the CORA studies by my mentor, Professor Ziegler, have shown that in diabetes and pre-diabetes, so when you have obesity, it is in itself a risk factor for neuropathy. And we can address obesity, we can address smoking, we can address dyslipidemia, we can address hypertension, we should address alcohol abuse. And patient hygiene, so if you have neuropathy, you have more vulnerable feet for ulceration and so on. So subjects with diabetes should be taught how to take care of their feet. And you see some examples here. And bariatric surgery, to be more modern and to come back to obesity, has shown improved cardiac autonomic function, various parameters, especially in those gray solid bars in those with type 2 diabetes. So in conclusion, this is a boat. I'm not sure if it's a Greek boat, but it's certainly a boat. That's not very solid, but at least it's the skeleton of the boat. Now, why is it relevant? Well, for many reasons. Among other reasons, it used to be in the reception hall of the other hotel, I mean the other building, not this, which is the main building, the one we used to stay in the previous years. So this is or was on the ceiling in the reception area of the other building. But it's also what we can use to travel, take our patients with us and travel in a journey without trouble and full of glycemic serenity. So in type 1, glycemic control is crucial for neuropathy prevention. In type 2, glycemic control is not entirely enough. And when you have neuropathy, so you cannot prevent it so easily in type 2 with just glycemic control. But when you have neuropathy, you should obviously try to improve it. And you should do that by carefully and not too rapidly improving glycemic control. And nota bene, we need, or we appear to be needing, new approaches to neuropathy or new evaluations of neuropathy, and there's progress in both. So that's optimistic, perhaps less than we would like to, but still optimistic. And this is my final slide. Neuropathy in diabetes, one cannot begin it too soon. The meaning is that it is never too early in diabetes to develop neuropathy. We used to be taught that you must have had 5 or 10 years of diabetes in order to develop neuropathy, because it is, or could be, according to the myth, a very late complication. But it is not a late complication, because the German diabetes study and others have shown that you can develop neuropathy even during the first 12 months of diabetes. And we have mentioned that even in pre-diabetes, which is not even diabetes, you may have neuropathy. That is the science. But on this slide, the science is coupled with poverty. And William Butler Yeats, who was from Ireland, and he was not a physician, but still received a Nobel Prize, but for literature, not for medicine. So he wrote a poem called Brown Penny. So it's a British coin, and tossing a brown penny and seeing heads or tails. And there's a little girl saying, sorry, a little boy saying that he's in love with a little girl. And somebody says, come on, you're too young to fall in love. But the poet is saying, oh, love, one cannot begin it too soon. So neuropathy in diabetes, one cannot begin it too soon. Thank you very much.